Okay, part 2 of chapter 45. Got a little bit more voice back, so hopefully this will go okay. So we'll now start to talk a little bit about the specific medical conditions, or at least the systems, and some of the things that we may see in the elderly patient. So we know that there's a number of respiratory disorders that affect us over time, probably one of the biggest ones being COPD. But heart failure, which is technically a cardiovascular issue with sequelae that affects the respiratory system. So there's also the possibility of lung cancer, asthma, which they may have battled their entire life, and anemia, which is not really, again, not really a respiratory disorder. It's a blood disorder, but it is usually going to crop up with a little bit of shortness of breath. So we have all of these things which we've talked about as we've gone on through the course. Not to forget that myocardial infarction, pneumonia, and pneumothorax or pulmonary embolism may also be a problem that they deal with. Pneumonia is probably one that we need to pay the most attention to because it is one of the most common causes of death in the elderly. Very, very frequently we will respond to nursing homes for patients who have complaints of difficulty breathing, chest discomfort, fevers, chills, and so on and so forth, and only to find out that eventually that they are diagnosed with a pneumonia. And this can be either an infectious pneumonia, in which many cases it is, or occasionally it is a aspiration pneumonia. As we mentioned, they have difficulties with swallowing and chewing and so on and so forth, and that can crop up as a that can result in them inhaling some of their foodstuffs or drink, and eventually developing an infection as the body tries to isolate and wall that all off. Typical signs and symptoms of pneumonia include fever, chills, pleuritic style chest pain, which is more of a rub or a pressure like chest pain, tachypnea, dyspnea, a productive cough or a cough with a present, and an altered mental status. Again, very supportive care. Many of them are dehydrated, but we have to be careful. If we're talking about patients with pneumonia, there's a very good possibility that they probably have a history of congestive failure as well. Not to mention, if they have crappy, goopy lung sounds, sometimes it's hard to determine whether it's actually pulmonary edema or is it pneumonia. And so we have to be very cautious when we treat them. I'm not saying don't give them fluid. I'm saying be very judicious in the way you give it and be very cautious while you're administering it. Suspect a pulmonary embolism with a sudden onset of dyspnea. Remember, many of them are being treated to try to lead off any clots from forming. So in those cases, they may be on things such as Coumadin or aspirin or Pradaxa or something along those lines. Now, maybe they haven't filled it recently. Maybe they've run out. Maybe they haven't had their levels. People with Coumadin go in and frequently have their blood clotting checked. And maybe they haven't had their tests lately, and so they're a little bit more on the clotting side than they are on the non-clotting side, and so they could certainly develop a pulmonary embolism. Pulmonary edema is often as a result of left-sided heart failure. Remember, the side of the heart that fails backs up into the system and where it gets the blood. So the left gets it from the lungs, and the right gets it from the body. Respiratory failure, arrest, and cardiac arrest certainly can ensue very rapidly. We're talking about people who are worn out. CPAP can be very helpful, particularly in congestive failure. Bag valve mask ventilation. Remember, it's not only for people who aren't breathing, it's for people who are not breathing adequately. And remember, try to keep the patient in a sitting position. Can you ventilate a person sitting up? Absolutely. They just have to lean their head back against the back of the cot so they can, you can have something to press against. So ventilatory capacity, oxygen uptake, those are going to decrease with aging. Things are worn out. The interfaces are just not as good as they used to be. Many of us that may have lived in old houses or had old vehicles, which is probably all of us at one point or another in our life, know things get worn out, and we have to replace things. Parts have to be replaced. It's not that easy in a human body. We can't just easily go and take out your lungs and put in new ones. You can't mass produce this, at least yet. So in the presence of a respiratory disorder, elderly patients can easily become hypoxic. So if they've got COPD or CHF, they're already not taking big breaths. They already have worn out interface in their lungs, so they're already at a disadvantage. Then we throw some sort of a respiratory disorder on top of it, and they're that much more disadvantaged. And then always consider hypoxia as a cause of an altered mental status in the elderly. Remember, altered mental status, there's a few things we can treat very quickly, very easily. Things such as hypoxia, hypovolemia in some cases, but hypoglycemia. Those are very usually easy things for us to fix. Give them a little fluid, give them a little oxygen, give them a little sugar. Those are quick fixes. Okay, cardiovascular disorders. Of course, ACS, hypertension, heart failure, all remain very big potentials for our patients as they age. I've also mentioned that dysrhythmia has become somewhat common in our elderly population. As the SA node wears out, the possibilities of things such as atrial fibrillation or bradycardias certainly become a little bit more common. Aortic aneurysm and dissection, really it probably does grow a little bit more in the elderly population. It's certainly something to be considered. Cardiogenic shock is probably a little more common in the elderly population than it is in people during their normal adulthood, simply for the fact that more systems are already worn out. Syncope can be a very common problem with the elderly. Things that this may include, and remember, in most cases, we consider syncope to be of cardiac origin until proven otherwise. Syncope can be as a result of hypotension, potentially maybe from some sort of shock, could be from a dysrhythmia of sorts, or could potentially be as a result of some of their medications. So remember, many of them have that polypharmacy issue. Silent MIs, atypical presentations, those increase substantially as the patient ages. Remember, this is the prime population that has silent MIs and atypical. Acute MIs may present as abdominal or epigastric pain or simply shortness of breath rather than chest pain or discomfort. Very, very common. If you have the capabilities of doing 12 leads, it probably would behoove you and be in your patient's best interest to consider doing 12 leads on most of your patients who are complaining of abdominal discomfort, unless you have a direct reason to suspect what it is, such as they're explaining to you that they have bloody emesis, bloody stools, dark tarry stools, have suffered some sort of a trauma. If you have kind of a non-specific complaint and not a lot of additional details to go with your complaint of abdominal discomfort, consider a 12 lead. Suddenly becoming weak or short of breath, fatigue, syncopal episodes, dyspnea, faintness, altered mental status, all of those have the potential to be warning signs or red flags that this patient may be having an MI. Again, we work towards an SpO2 of 95% or better and are continuing with our oxygen, nitro, aspirin protocols, and then start an IV and transport. Considering aortic aneurysms or dissections, patients who are complaining of abdominal pain, back pain, unexplained shock, loss of pulses, particularly in the lower extremities, sensation and function, so CSM disruption, and consider all causes of shock in elderly patients presenting with any signs or symptoms of hypoperfusion, because they could be septic very easily. They could have suffered a back injury and have some sort of a neurologic injury or a neurologic shock because of maybe even something as simple as a compression fracture in their spine. Certainly cardiogenic shock, anaphylaxis, because they're on so many different meds. So there's a whole big gambit that we have to at least consider in our shocky-looking patients. And remember, a little bit of tachycardia in the elderly patient may be normal, but it may be completely abnormal because maybe they typically run much slower. So it's good to know where that patient normally is so we can make a comparison. Patient's on a bunch of drugs for hypertension and their blood pressure's hanging right around 110 or so. Find out, what does your blood pressure normally run? I see you're being treated for high blood pressure. What is your normal blood pressure? Because that 110 may be 40 points below what is actually normal for them. Sometimes we have patients that are non-compliant with their medications. That exacerbates the problem. So we may have patients who are not able to afford them. Maybe they're having issues with remembering to take them. So find out when they're taking them, where are they getting them. I've had a number of patients, particularly snowbird, that will go south for the winter, down to, say, Arizona, and they'll stock up on all their medications while they're down there by taking a day trip into Mexico and buying them in Mexico. Well, buying them in Mexico, sure, does save them some money. The problem is the FDA, which does make a lot of our medications more expensive, also has many assurances that it's a high-quality medication. Some of those assurances are lost when you go outside the United States, particularly into Mexico, where many medications can be bought over the counter without a doctor's prescription, but that guarantee of quality is not there. Several factors can lead to non-compliance, so I mentioned some of those. Neurology. So considering hypoxia, infection, hypoperfusion, hyperthermia, hypothermia, endocrine disorders, poisoning, overdose, trauma, neurologic status of the altered mental status patient. All of these potentials we've talked about, and if we go back to our old mnemonic that we've used, AEIOU tips, it helps us to recall most of those. Additional causes to consider: stroke or TIA. Remember, TIAs are basically mini strokes that will come and go within a 24-hour period. Sometimes you won't be able to guess the difference. You will think, oh, I know for sure that this is a stroke, and they snap out of it almost immediately. Seizures, dementia becomes a much bigger issue with the elderly patient, as there's various causes of dementias, whether it's something that's a progressive thing such as Alzheimer's or even Parkinson's disease. Both of those have changes in their mental status. Sometimes it starts very slowly with them forgetting some of the, what you would think are common things for them to remember. But a lot of times they still have very good, vivid memories of the early parts of their life. It's just the stuff that's more recent that they have a hard time with. Your protocol probably will specify using a certain stroke screen. Most people are using the Cincinnati Pre-Hospital Stroke Scale. However, you may also choose to use the Los Angeles Pre-Hospital Stroke Screen. Cincinnati's pretty easy, but I've also seen that there's a new one that's come out. The name escapes me right now, but it's not being used very widely. But if you do a little Google search for some different stroke screens or mental status screens for the EMS, you'll come up with several interesting tools to use. Seizures. I haven't noted particularly in my career that we have a lot of elderly people who have seizures. There's a lot of elderly people on anti-seizure medications. And this could be for some of their various neurologic disorders that they have. They may have had seizures at one point, but for the most part, I haven't gone to a lot of people who are having epileptic style seizures. the seizures I have gone on in the elderly population usually were related to a stroke. So TBIs are a possibility. Remember, even a fall from standing can cause a significant brain bleed, particularly the older you get and the more health problems you have. Hypoglycemia, alcohol withdrawals. There are lots and lots of elderly patients who are addicted to alcohol and even some drugs. Vertigo is fairly common, or dizziness from strokes. Other changes in positions where they're orthostatic potentially. Meniere's disease, which we mentioned a few chapters back. Delirium. Remember delirium? The difference between delirium and dementia is delirium is a sudden onset change in mental status and behaviors, often that have an underlying medical cause. Whereas dementia is a long-term chronic thing. Delirium, many times patients can be brought out of that delirium and return to a normal function. Dementia is progressive. Parkinson's is more common in the patients over the age of 50. Remember, Parkinson's is related to the degeneration of the dopamine-producing cells in the brain, and it gives us postural rigidity, makes them almost have robotic-style shuffling movements, tremors, loss of facial expressions, and then progressing into some dementias. The Alzheimer's is due to the brain degenerating itself, and usually actually shrinking up. Depression is common in patients with Parkinson's because they know that they're going. They're cognizant enough to realize that their body is degenerating and that their mental faculties are leaving them. So yeah, depression is fairly common. In Alzheimer's patients, they may know, but a lot of times they're pleasantly confused. Renal and genitourinary issues. UTIs are huge. Tons and tons of UTIs. Urinary retention is a possibility. Urinary tract infections. A lot of elderly patients that are bed confined in nursing homes and facilities will have Foley catheters, and the Foley catheters can lead to them having urosepsis. Catheter care is huge. So, poor hygiene due to their physical disability, inability to get in and out of the bathtub, it's going to increase the possibility of urinary tract infection. Their incontinence, they may be wearing some briefs or adult diapers. That helps keep the urine right up against their body and making it in constant contact, so therefore it kind of festers. Loss of pelvic muscle tone can lead to some of their incontinence, as well as decrease in their nervous system, their ability to sense, as well as their immobilities. Urinary retention increases the risk of a UTI. Why is that? Remember that the urine is a waste product, and as we our attempt is with our waste products to get rid of them. So if we keep the waste products in our body for longer, the chance of not getting rid of some of those bacteria that maybe have been pulled out of the body and they're just being kept in there and they are allowed to fester. Certain medications may also cause this. Prostate gland problems I've mentioned. Higher prevalence of UTI in patients with a Foley. Nausea, vomiting, and diarrhea, constipation, very common side effects of many drugs. Decreased fluid intake, often very dehydrated. And constipation can lead to a bowel obstruction, meaning that everything basically kind of seizes up in there. And when they get the bowel obstruction, things just start backing up. I have picked up patients who were vomiting fecal material. They were so backed up. So abdominal pain, regardless of the severity, no matter how vague or specific, has the potential to be life-threatening. Don't take it lightly. It can be anything from an aortic aneurysm to an MI to a severe bleed, bowel obstruction. It might even be something such as pneumonia. Endocrine, the endocrine disorder, type 2 diabetes is common as people age. Remember, this type 2 is when they don't produce significant enough amounts of insulin. Type 1, they don't produce any. Type 2, they have insulin that's either resistant to working with the body or just not insufficient. There's just not enough of it. So diabetic emergencies obviously can lead to altered mental status. Remember, with the 2 times in which we make sure and check blood glucose, altered mental status, and people with diabetes. Other than that, there's really no need to be checking blood glucose on everybody. Consider hyperthyroidism, hypothyroidism, complications of corticosteroids. A lot of elderly patients might be on steroids for some various reasons. Those can lead to things such as Cushing's. So major surgery, infection, or illnesses such as an MI can increase the risk of DKA or HHNC, which might be a good time to go back and just briefly review those. Remember, DKA typically is it's a high blood glucose, but usually under 600, where HHNC or HHNK is usually over 600. The major difference, they both look dehydrated, is in the non-ketotic version, they're not creating ketones. And so therefore, they're not going to have possibly the signs of Kussmaul respiration. They may not have the odors of acetone on their breath. HHNC usually has a very high mortality rate. And then treat our diabetic emergencies as we would anybody else. Infectious diseases. We've mentioned pneumonia several times. Influenza. Most elderly patients are recommended to get a flu shot on a yearly basis. Sepsis, herpes zoster, or shingles. If you're not recalling shingles, shingles is the chickenpox virus, or herpes really, that has affected a nerve, and it looks like a band. It follows the dermatome maps of the body, and it is extremely painful, causes some welts and some weeping sores. Consider infection and the possibility of altered mental status. Again, Foley catheter or indwelling catheter, people in extended care facilities, people on immunosuppressants, people that have pre-existing illnesses, all are potential for infectious disease. One of the biggest concerns we have for people that live in communal settings, such as nursing homes and dorms, is that there's a higher risk of them to develop a meningitis. This goes on to talk a little bit more about shingles, the herpes zoster, where it lies dormant along a dorsal nerve root, manifests with severe unilateral pain, often with vesicular or essentially blistering rash. And it most often manifests on the trunk, so usually it's around the chest, but it also can affect the cranial nerves and the head and the face. Very, very ugly. Musculoskeletal pain, extremely common in the elderly. Most people have osteoarthritis. Some have osteoporosis. Ladies that are postmenopausal are at a much increased risk of osteoporosis. They just may have simply decreased range of motion. As people age, some of their injuries from earlier on in life come back to haunt them in the form of various aches and pains and arthritises. And they may be fractured with much less force than it would take for most adults. So splinting hip fractures, best to use basically padding, so pillows and blankets to pad some support, use a little strap around there to kind of give it a little stabilization. The slings, they have pelvic girdles and whatnot that have kind of become popular. those have not been proven effective, particularly in the field setting. They work pretty well in a clinical setting, but they're not particularly, and they're of course not used for hip fractures. So another great item to use is the vacuum mattress. So injury prevention becomes very important. Sometimes a simple little fall or fracture ends up being the straw that breaks the camel's back, and that patient never is able to return home again. Spondylosis. Spondylosis is the degeneration of the vertebrae and vertebral discs, and that can affect the neck and back. Usually causes them to kind of have a hunched over look about them. You got to be very gentle, very careful when moving them. A lot of times, every little bump in the road hurts. Fractures can occur with very little force in these weakened bones, which can become pathologic fractures. So simply twisting or moving a certain way can actually cause a fracture. And a minor fall can result in fractures of the vertebrae, the ribs, and long bones. And it can be unclear whether the fall resulted in a fracture or the fracture caused a fall. In many cases, we actually probably break a hip before we fall down, rather than the other way around, just the way that hip is designed. Hematologic disorders, so when we talk things such as anemia, leukemias, coagulopathies, the anemic patient often is very weak, fatigued, will have some dyspnea upon exertion. The various coagulopathies can result from immobilities, so they're much more prone to clotting. That's why many of them are on those medications. And then some medications will impair blood clotting, including a lot of herbal remedies. Your anemias, they can result from a variety of underlying causes, such as renal disease. So as the kidneys start to fail, the body's ability to appropriately feed hormones to tell the bone marrow to start to make more red cells is decreased. Decreased nutrient intake, got to have the iron in order to have healthy blood cells or absorption. Occult or unnoticed GI bleeding, other illnesses. Behaviorally, there may be a number of psychiatric illnesses on top of their delirium or dementia that they may already have. Remember that we may have a lot of people who are very depressed. So behavioral changes, remember initially consider all the potential medical causes before defaulting to a behavioral issue. So never assume that their abnormal behavior is due to dementia. Try to determine what their baseline is. So it's important for us to try to talk to other people and find out what is the norm for this person. The patient may be very confused, they can be disoriented, they can be very frightened, and they need to be prepared to restrain as necessary. I mentioned before, depression and suicide are fairly common in this age group. So don't overlook the possibility of depression in the patient with a flat or sad affect who gives slow or halting responses to questions. Even noticing it and mentioning it to the ER staff may help them do a little bit further questioning with the patient to determine if this actually is something that's affecting them, and hopefully can lead off any potential suicide ideations. All right, so things that may appear to be accidental may in fact be a suicide attempt. Collisions in many cases. So an elderly person pulling out into traffic, it may actually be a suicide attempt rather than, oh, well, mom's just not a good driver anymore. Toxicology. We have increased plasma levels of drugs. So we're going to have diminished liver and kidney functions, decrease in plasma proteins, decrease in the total body water, decrease in adipose tissues, as well as the polypharmacy. They can have some oddball interactions. Don't overlook intentional overdoses. Suspect a toxicological emergency in a patient with an altered mental status, behavioral change, or abnormal vital signs. Many times it's really not an intended, but it happens. Collect a thorough medication history. Take the little pill sorter with you. Take the bottles with you, any lists that they have. Check the dates. Compare with the amount that's present. I mentioned this before. Look for those clues of an inadvertent or an intentional overdose. You know, if their Friday pills are all missing and it's only Wednesday or Thursday, do they believe that you know, oh, I forgot to take my pills today and went and took the second set of pills? It's definitely something that has to be considered. So trauma. So what are the 4 major mechanisms of injury in the elderly? Motor vehicle collisions and falls being very significant. Violent crime and burns are also very significant. So shock. Consider all causes of shock. Sepsis, cardiogenic, hypovolemic are very common in these populations, and this is why it's very important for us to look closely at the mechanisms or the nature to try to determine what possibly has happened. And sometimes it's very difficult to determine, so we have to do a lot of detective work. We're going to continue to ensure an adequate open airway, oxygenation en route, treating them with IV fluid access or IV fluids, using isotonic crystalloids per protocol. But remember to be cautious. Yeah, the patient has a history of congestive failure. It could potentially be the straw that broke the camel's back. Fractures are very common. Pad the splints to prevent injuries to the skin. Remember, they already have weakened skin, very thin skin, so remember to pad the voids very well. Cervical collar, make sure that we're not forcing their neck into a unnatural position for them. If they have some curvatures, we may not be able to even place a C-collar. We may have to get by with just doing manual stabilization or trying to use towels or blankets to try to give them extra support. Pad appropriately with their kyphosis. Burns, lower temperatures and shorter exposures can cause burns because of the less elastic, less resilient skin, and then decreased sensitization. They may not even realize that they were burned. Just simply that neurovascular, the neuro breakdown, they don't even feel the pain anymore. Impaired mobility, they may not be able to move quickly away from the source of the heat. They're of course at a high risk for hypothermia. Their body doesn't maintain heat very well. If they're living on that limited budget, they maybe don't want to turn the heat on. So remember to treat for shock. Environmentally, their impaired thermoregulatory function put them at that higher risk for heat and cold related emergencies. Very limited ability to maintain their homeostasis, so they don't quickly adapt to their environment, and then maintain a high index of suspicion. Sometimes even in nursing homes we have patients who become hypothermic. There's a good case that somebody was telling me about that they had a dementia patient who they had each room in the nursing home had its own individual heat and cooling unit, so that patients could adjust it so they could be comfortable. And this dementia patient went and in the middle of winter cranked on the air conditioning in their room thinking they were turning on the heat. And the patient was found to be altered mental status and had a very, very low core body temperature, and the room was just freezing cold when the medics got there. So it's even something to consider in those sorts of settings. All right, as we wrap up the chapter, the number of elderly in the U.S. Are at its highest level in history and probably going to continue to rapidly increase. Increasing age is associated with increasing risk for illness and injuries. Patience, respect, gentleness, efforts to overcome challenges in communication are all important parts of providing high-quality professional care to our elderly patients. Communication difficulties can be minimized by getting the patient things that they need for daily life, such as their dentures, their hearing aids. Normal age-related changes, medications, and illnesses can create significant diagnostic challenges for us. Illness and injury may present differently than what it does to us normally in our adult and younger populations. And the elderly patient may not complain of the level of pain expected, might not be able to exhibit the typical homeostatic responses. They're at an increased risk for illness and injuries. Common complaints include dyspnea, weakness, chest pain, discomfort, or dizziness, injuries from motor vehicle collisions or falls. Side effects of their medication are very common, and principles of assessment and management are still going to apply. Many of our elderly patients are very reluctant to leave home.